This is the Spectrum Public Affairs Network.
This is Feedback with Scott Wenner on the Spectrum Public Affairs Network.
Drug addiction, chronic pain, some of the things that are stressing out people in the modern day. And just when we think we have the drugs to help us with it, those drugs themselves are starting to become a problem. Good morning, I'm Scott Wenner, and this is Feedback on the Spectrum Public Affairs Network. And today we're going to talk about the proper way to use prescription medication with Dr. Lynn Webster, who's Medical Director of Lifetree Clinical Research and Pain Clinic and President of the Utah Academy of Pain Medicine. Welcome to the program, Doctor.
Good morning.
We want to talk about one thing in particular, and that's methadone abuse and the way people can get into trouble using methadone. But let's talk first about what is causing our culture to get involved more in pain medication. Chronic pain syndrome is something I've heard about for quite a while, and it's where people have a kind of pain in their body that they just can't get away from, and regular pain medication doesn't seem to work for it. And from what I understand, this also is what leads a lot of people into addiction for other kind of illegal drugs to try to reduce the pain in their bodies. Is that true?
Not exactly. First of all, chronic pain is pervasive. We have about 70 million Americans across the country who experience chronic intractable pain.
Okay, and how do you define chronic pain as opposed from I stub my toe and it hurts and it eventually goes away?
Basically, there are two different groups of definitions. One would be the acute pain, which lasts for a short time, and you would expect full recovery from it. So if you stump your toe or you break an ankle, you would expect to recover from that within 3 to 6 months. Chronic pain is a condition where you experience unrelenting pain. It can be intermittent, but it's usually pain that lasts for a long period of time, more than 6 months, and it could remain the rest of your life.
Okay, and why aren't we treating what's actually causing the pain as opposed to just dealing with making the pain go away? Because pain doesn't just happen on its own. Something has to cause this pain to happen. If you have like a leg injury, a back injury, a spine injury, something like that, I would think treating that cause of the pain would get rid of the pain.
Absolutely, if you can do that. Unfortunately, much of the cause cannot be treated. Sometimes there are irreversible conditions. Say, for example, somebody who's had diabetes for a long time and they've developed peripheral neuropathy. That's a pain disorder of the nerves in the extremities. That's due to the condition of diabetes. The best way to treat or prevent that from occurring, that type of a chronic pain condition, is to manage your diabetes well. But for some people who develop that problem, and that's quite prevalent, there is no correction of that disorder or that pain condition. It's a matter of trying to manage the pain.
Okay, so you cannot undo the damage that the diabetes has caused in order to get rid of the pain.
Not yet. We don't know how to do that.
All you can do is basically stop it from getting worse, hopefully, and then try to deal with the pain one way or another.
This is an example of what you're trying to do is optimize your treatment, minimize the pain, maximize the comfort of the patient so they can function at a high level.
Are the instances of people coming down with chronic pain increasing in this country?
Well, I don't think that the incidents are, but the number of people are, and that's largely because of the demographics of our society. We know that about 1 out of 3 people will experience chronic pain in their life. But unfortunately, that's going to increase as over the next decade or two, because as the baby boomers enter into their 60s and 70s, it's estimated that probably 1 out of 2 Americans are going to be experiencing chronic pain. It could be general arthritis conditions,
right?
But the pain is going to be of sufficient magnitude that there's going to need significant painkillers in order to be able to function at a reasonable level.
Okay, so your definition of chronic pain then is it's really painful and it lasts for a long time, or that it's painful and it never goes away?
No, the duration isn't as important as that it lasts at least 6 months.
Okay.
And for some people, it could lessen over time. It can significantly lessen. In some instances, it can even disappear. So say, for example, somebody who has a bad hip and they need a total hip replacement, and that the pain is really bothering them so that they can't walk around the block, they may have that bad hip for a year or two before they have a total hip replacement. Once they have a total hip replacement, their pain may disappear. But for having the pain for that 1 to 2 years is a chronic pain condition.
how do we deal with most chronic pain? Is it how we deal with most other kinds of pains that we have? We pop a few pills, we take some Advil, some Motrin, some aspirin, something of that nature, and chronic pain, we just end up taking more severe medication in order to try to get rid of it?
It doesn't really matter if it's acute or chronic. It's the magnitude of the pain that determines what you do about it. Some people can have chronic pain that is manageable with very little. It could be that they can live with their chronic pain without any treatment. Or they may seek conservative or alternative therapies, which can be adequate. Over-the-counter type of medications can be adequate for a lot of people with mild to moderate chronic pain.
Okay, but you mentioned alternative therapies. Are we talking about something that isn't pharmacological, as opposed is like exercising or doing some kind of physical therapy in order to get rid of this chronic pain?
Yes, precisely.
Or at least deal with the pain, I should say.
Precisely. In fact, what the way we look at it is that we can address chronic pain conditions in either a pharmacologic or a non-pharmacologic way, and that means use medication or something other than medication. When we look at something other than medication, then there are a lot of different treatment opportunities. One would be surgery if you have a bad total hip or a bad knee. Another would be some type of injections that pain doctors can provide. And in other cases, it may be some type of an implant, but those are more aggressive interventions. Alternatives to that would be physical therapy, psychiatric care, antidepressants. All of these things are a component of the alternative treatment modalities.
Oh, okay, but let's look reasonably at the way our society is formulated today. People don't want to put that kind of work into dealing with a problem. I can understand the surgery. I had a herniated disc in my back about 15 years ago. I had surgery in order to fix that problem because it was pinching my sciatic nerve and causing really, really severe pain all the way down my side and my leg. Well, I never had back problems up to that point. I just had the pinched nerve. Once they did the back surgery, the pinched nerve got better, but now all of a sudden I have back problems that have happened for the last 15 years since I had the back surgery. And it's never really quite gone away. Now, if they told me at that time, you could do physical therapy, you could try to improve your back and keep you from having pain in the future, I would have opted for that. But they didn't do that. They just said, here, take these pills, take these pills, take these pills, and that'll help you deal with the pain in your back. And hopefully you'll get to the point where you don't notice it anymore. Is that kind of the easy way? And a lot of doctors and patients take that easy way to try to deal with chronic pain as opposed to something like physical therapy, which may be a little bit more time-consuming and involved?
I don't think it's so simple. It's not a matter of either this or that. It's usually a combination of different treatments. And every individual with each of their specific type of pain requires an individualized treatment approach.
Well, I'm not talking about what we should do, though. I'm talking about what do you think happens in our culture. I think that's what happens. We kind of take the easy way out. We just throw pills at it.
Many patients do use pills. Okay. Many physicians use pills to help with the symptoms and improve their function. Absolutely.
And then we become dependent on those pills and pain medication, correct?
Well, you can become dependent, but that's...
And then their effectiveness kind of loses its effectiveness over a period of time.
Some of the medications will lose their effectiveness over time, but not with everybody. You see, it's very complex because in your instance, when you had the herniated disc and it was pinching a nerve, for some individuals, they don't need to have surgery. For other individuals, you do need to have surgery. And generally...
if you'd felt this, you'd know I needed surgery.
I believe you. If in fact, what you're describing here, it sounds like, is that you had a neuropathic component. That is a nerve component to your pain.
And I'll tell you, even after the surgery, it took 2 months for that pain to really completely go away from the pinched nerve. I guess that long for the nerve to recover.
Well, it's not just the nerve to recover, but actually the central nervous system has rewired itself after it's been exposed to pain for a period of time. The brain, the spinal cord, and the nerve have actually changed the whole electrical wiring so that you have a different wiring system. So very small amounts of stimulus that would normally not hurt now become painful, and the recovery of that is sometimes protracted, and it takes a long time for it to get back to the baseline. You're fortunate. Most of the people that see me don't recover from that. And so then they're looking for some way to get rid of that pain. I mean, I can tell from
So what are you saying? That even though my body got so used to being in pain that when the thing that was causing the pain went away, it still sent signals to my brain that I was in pain?
Yeah, actually the nervous system adapts and it actually changes. It's not the same nervous system. It actually sends out ways to modify the actual structure and function within the nervous system.
Why would our body do that? That seems counterproductive to what our body should be doing.
Well, I don't understand that. I don't think most of the scientists understand either.
Okay.
I would assume that there's something in it that's protective, but I don't know. It is not protective. It's a maladaptive. We call that a maladaptive function of the chronic pain condition.
Okay, so that's one of the things you have to deal with when you're dealing with patients to help them get over or deal with their chronic pain.
What we have to help them get over is that it may not change. It's going to be around for a long time, if not the rest of their life. And what we want to do is minimize the impact on their quality of life.
Okay. Medical Director of Lifetree Clinical Research and Pain Clinic. It's and Pain Clinic. What is the Lifetree Clinical Research part of this?
We do clinical research on a whole spectrum of different things. A lot of it is on investigating new medications for the treatment of pain. They're several years away, but one of the areas that I'm interested in is helping pharmaceutical companies develop medications that have less abuse potential, that are safer and more effective.
Let's talk a little bit about pain medication. What does most, if you can generalize it in some way, what does most pain medication do to the body in order to help people deal with pain?
It depends on which medication you're talking about. If you're looking at aspirin or if you're looking at ibuprofen and like the Vioxx drug that was taken off the market, what you're doing is decreasing the little chemicals that produce pain. So it's an inflammatory process that they're trying to reverse. So with that group of medications, you're actually trying to minimize the production of the chemicals that lead to a painful response. There are other medications.
So wait a second. When your body is injured, your body is in pain, and the way it tells your brain that you're in pain is it produces a chemical in your body that signals that to your brain.
If the injury is outside of the spine, out what we call the peripheral parts of our body, yes. Actually, what happens is
it's like a warning system for your body.
Absolutely, that's the acute phase.
Yeah, but because generally speaking, pain is a good thing because it lets you know that something's wrong.
When it's acute, it is a protective mechanism.
Okay.
When it is chronic, it becomes then a maladaptive as opposed to an adaptive process, and it becomes destructive.
Okay, so most pain medication then keeps your body from producing this chemical that can overload your brain with pain information.
No, not most medications. A certain class of medications, like the non-steroidal anti-inflammatories or aspirin type of drugs,
over-the-counter stuff.
Well, the over-the-counter, yes, for the most part.
Ibuprofen, aspirin,
right.
Things like
but
that.
But Vioxx, Celebrex, a number of other medications like that are prescription, and they're more powerful. They work in a similar way. But there are other classes of drugs that work with different mechanisms. You look at the anticonvulsants, for example. They work on decreasing the effect of those chemicals that are set down a pathway to produce a painful response. They decrease or blunt the effect of the abnormal chemicals that are supposed to produce pain. And they can work in the central nervous system, which means the brain or the spinal cord, or at the nerve terminal out distally. Then you have other medications like the narcotics, which actually blunt your pain response and decrease the amount of pain information that's received at the spinal cord level that then has to be taken to the brain.
We're talking with Dr. Lynn Webster, who is medical director of the Lifetree Clinical Research and Pain Clinic. He's also president of the Utah Academy of Pain Medicine. I'm Scott Winter, and this is Feedback on the Spectrum Public Affairs Network. All right, you mentioned the N-word, the narcotics. Would the morphine drip that I got after my back surgery be classified as one of those narcotics?
Yes, it is. Yes.
Would codeine be classified as that? Because they gave me something afterwards called Tylenol with codeine, just for a couple of weeks, and that was prescription as well. Would that be a narcotic?
It is. I want to clarify this term narcotic a little bit. Has
it gotten a bad rap? Because when you say narcotic, people think of the guys in the with the guns and the uniforms with the police department who are on the narcotics task force.
Yeah, and that's why I want to clarify the term a little bit. It is a slang term. and it does imply the negative aspect to the drugs that we use that are really called opioids or opiates. Those are
here's the problem with that. You can call a cop who arrests you a narc, but you can't call him an opie. So you got to be careful about that. But what you're saying is narcotics is not a medical term?
It's not one we use, no. I mean, we use it from time to time, but it's not a clinically useful drug a term. No, it is not.
Okay, but the drugs we just mentioned, the morphine, the codeine, things like that, they are in that general classification.
That's correct. We call them opioids or opiates. You may hear either one of those, and you'll see it more and more. I think even in the press, journalists are using those terms commonly now. And that's largely because narcotics are thought of as the illegal part of the world with these, and opioids and opiates are intended to be meant for the legitimate purposes of opioids.
And how do these class of drugs work differently in dealing with pain than the ones you previously mentioned?
There are some overlaps in the mechanisms, but for the most part, they decrease the amount of pain information, electrical conduction of information to the spinal cord, and then as it is supposed to advance up the spinal cord to the brain where it's perceived, it'll decrease actual units of pain information. For some people, that is a kind of a blunting effect of the pain response. The unfortunate thing is there's a tremendous variation amongst people. There's a tenfold variation in the way an individual respond to a drug to the same stimulus response. So let's say we all have the same fractured leg, and it's fractured in the same spot in the same way, same amount of tissue injury. There is a tenfold difference in the amount of pain individuals may be able to experience with that, meaning that we don't experience the same amount of pain because of largely our genetic makeup and some of our environmental makeup.
So you could have a fractured leg and experience pain one way. I could have a fractured leg and experience it totally different.
Correct, and they're both equally valid. Equally valid. That's very important because oftentimes people see others who seem to be complaining a great deal about their pain, and they think that it's not possible because I had a similar problem.
Oh, you're just a big baby. You're whining about it. Yeah, it happened to me. It wasn't any big deal.
Right. Well, that is inappropriate.
And this is like when people say, I have a high tolerance for pain. They're kind of bragging about that idea that they can put up with a lot and they don't have to use all the medication or get the special treatment that they see other people getting. And that's not fair.
Well, I think they ought to go to church and thank God because they were blessed with the right genes that allow them to tolerate more pain than others.
Okay, do doctors and physicians take that into account when they are prescribing pain medication for people, or do they just look at the injury and say, well, the last 10 patients I had that had this type of injury, they needed this much pain medication, so I'm going to prescribe that for you. And then you run into a problem with a patient who maybe has a different genetic makeup, because every drug I've ever taken from a prescription from a physician has always said the same thing. Take it this amount for this long until the bottle runs out. I don't see the doctor saying, you're a different kind of person. You have a different genetic makeup than that other guy. I should change this prescription for you.
Most doctors don't take that into account.
They need to, though, right?
Well, I think they do, but unfortunately, it requires a lot more education. There's very little taught in medical schools or in residencies about what I've just said. And so most physicians are not aware of the huge variability that we as human beings have in our response to pain, let alone the same huge variability in response to the pain medications.
Aren't aware of it or don't agree with you?
Both. There are, I would say most physicians, if they were given the facts and the data and the information, would understand and would probably accept what I'm saying. There are, however, individuals who simply will refuse and think that they may actually think that the pain is a reflection of a personality or their personality's ability to tolerate life. You know, they generalize and apply it to too many other aspects of their character.
Well, then this begs the question, what do doctors learn about pain management when they are in medical school?
I didn't learn anything.
You didn't learn anything?
Not anything in medical school. Now, that was a while ago.
Well, you were just taught to treat the problem, not worry about the comfort of the patient?
Well, I mean, we were told that after surgery they need X amount, just like you received, for a short period of time, and at the time I was in medical school, which was in the late 70s, we never treated chronic pain with narcotics. That was not something that was believed to be appropriate. We thought that at the time, if they needed a narcotic, that they had to be an addict to need it beyond a short period of time. It was clearly a lack of understanding, and many people suffered enormously because of that.
There kind of is a perception that if somebody keeps coming into the hospital asking for pain medication, they're just trying to score some drugs.
I think the general perception is that that's exactly what they're doing, and there could be many other legitimate reasons why patients need pain medicine.
Well, doctor, if this is correct, I can see one big problem here right off the bat, and that is people are being misprescribed medication for their problems, especially pain medication. And when you're talking about pain medication, you're talking about some very strong drugs.
Well, I think that there are a number of people who have not received the right prescriptions, but I think I need to point out that our largest problem is the undertreatment of pain, not overtreatment of pain. We have more people who have been undertreated or not treated for pain in America than have come anywhere close to the number of people who have maybe had too much medication prescribed.
Okay. Now, am I right in assuming that when you're talking about treating somebody for pain, you're not just talking about increasing a dosage? You're talking about other aspects that may help deal with the pain, not just a medical or a pharmacological aspect of it?
Well, in this moment, I'm referring to the pharmacologic treatment.
Okay.
But in treating pain, you do have to keep in mind that there are many other treatment modalities other than narcotics. And narcotics should not be the first line of treatment with most individuals.
What should be? Physical therapy?
Well, it depends. Acute injuries, physical therapy is very important. In chronic conditions, physical therapy tends to be less beneficial. Behavioral therapy is useful.
What about diet change?
Of course, diet, nutrition, weight, exercise, all of those things are very important. It all depends upon the magnitude of pain, that particular individual, and what the pain problem and the source is. Neuropathic pain is much more difficult to treat, that is, pain due to a nerve injury, than if it's not due to a nerve injury. It's very difficult to treat. And so for some people, exercise or mobility may actually worsen the pain condition and not help it.
Really?
Particularly with individuals who have significant nerve pain. So if you have a nerve that's injured and walking or manipulating it, overdoing that particular nerve can set some people back weeks to months in their potential recovery.
What, it inflames them? It actually makes it worse?
Not real sure, except that it probably does not the nerve at the periphery, but at the spinal cord and at the brain level.
I don't mean to smile, doctor, but I think that's about the third time you said I'm not sure. And it makes me think that doctors don't know as much as they let on sometimes about just what is going wrong with our bodies. Would you agree with that?
Well, I'll tell you, I don't know what's going on with our bodies very much.
And that's not a slam on doctors. What it is a comment on just how complicated the human body is. And so when you're talking about dealing with pain or pain management, in a lot of cases, you don't even know what's causing the pain on the person, and there's no way to find out.
Well, I think that's a very important point because there are a number of people that could come into my clinic in a lot of physicians' clinics where the source of the pain is not obvious. And yet I'm quite convinced that they are truly experiencing the pain that they are telling me.
You have to kind of learn to read people, too, to find that out, don't you?
Well, usually you watch for a pattern over time.
Yeah.
I mean, and people who are experiencing pain, the definition of pain is really something that generates a perception of a noxious experience. So it's an experience. It's not necessarily a cut or a fracture. It's not a crushed tissue. It's an experience. So it's really something that happens within the brain. And it may be as much influenced by our emotional makeup as it is by the tissue damage.
Well, it can certainly be aggravated by it, can it?
Absolutely.
Okay, because if you're injured and you're in a bad mood, it's going to feel worse than if you happen to be in a good mood.
Remember when you have little kids and they slip and fall and they scratch their knee.
Yeah.
They almost always scream, and you think that they are just dying because of their response, their emotional response to the pain. Now, for that child who is screaming, it is a frightening experience, and it's very real at the level that you perceive of their experience. But their tissue damage may not be so great. Their experience is enormous.
I'll tell you. Let me tell you a little story. 8 years old, day after Thanksgiving, I'm in the kitchen cutting some leftover turkey. Slice my finger. I go, oh man, I sliced my finger. 8 years old. Walk into the bathroom. I'm holding it under the cold water. My mother walks in. She said, what happened? I said, I was slicing turkey and I cut my finger. She pulls the finger out from underneath the water, looks at it and says, oh my gosh, that's down to the bone. I look at it and go, it is. And I start crying. It didn't hurt and it wasn't traumatic until that was pointed out to me. Yeah. I was able to kind of shrug it off before that kind of impact came to me. So like the kids you're talking about. If you run over to them and go, oh, my baby, my poor baby, you're just going to feed into it. And we kind of do that with ourselves. If we're not feeling good and we don't necessarily want to feel good or want to put the effort into it, we can make ourselves feel worse, can't we?
When we're adults and we've had a significant injury that's taken us out of our social loop, out of our comfort, our working environment where we've actually that's become our identity, then we begin to wonder. And all of those things contribute then to your experience of pain.
We're talking with Dr. Lynn Webster, who is Medical Director of Lifetree Clinical Research and Pain Clinic and President of the Utah Academy of Pain Medicine. I'm Scott Winter, and you're listening to Feedback on You're listening to Feedback on the Spectrum Public Affairs Network. Doctor, one of the things that's been in the news quite a bit in the last couple of years is the drug problem in the United States. And one of the things that a lot of people don't think about with the drug problem is that for the people trying to get off illegal drugs, there can be a lot of pain involved in that because the drugs that they're taking are probably to make them feel a certain way, maybe to get over some kind of mental, psychological, or physical problems that they think they're having. And if you just cut off that self-medication, if you will, that they're using, whether it's alcohol or any other kind of drug, they're going to go through a withdrawal process. And there are drugs that the medical community gives them to help them with the pain of that withdrawal. Is that correct?
Yes, that's correct.
Okay. We're now starting to see problems with the treatment to this problem, aren't we?
To the treatment of the withdrawal?
Yes.
Well, not that I know. I'm not sure.
I guess what I'm saying is, in trying to fix the problem, there's another problem that's popping up. And that is the things that we're using to try to fix the drug abuse problem are also causing a problem. Let me tell you what I'm talking about. Because this is something that you guys are dealing with, and that's problems with people using methadone. Methadone is a drug that is given to people who are trying to recover from getting over some other drug. Is that right?
Yes, but it's primarily used today for the treatment of chronic pain for legitimate purposes.
Oh, really?
Yeah, and so the problem is not from prescribing methadone for heroin addiction. The people who are...
That's surprising to me because that's really in popular media and culture and even news, really the only time I ever hear methadone being mentioned. As, this person is going to a methadone clinic or a drug clinic in order to get off of heroin or ecstasy or whatever they happen to be on.
Well, it's not effective in helping get off ecstasy. It's useful.
I don't know the particular. I haven't used heroin, so I haven't used ecstasy, so I don't know what it's used for. What is it used for in that respect?
Methadone is a narcotic in the slang term. Okay. Again, it is an opioid. It's got unique properties. It has unique properties that will help people who are addicted to other opioids like heroin restore their life, come off of those drugs. And the reason that it is effective is because it has what we call a half-life, meaning it stays in the body for a long period of time, and it'll occupy those receptors for a long period of time. Heroin is rapid in onset, comes on quickly, and it's eliminated from the body rather quickly. And when it's used repeatedly, the body gets used to it, and then when it's not available, the patient will, or the individual will experience withdrawal symptoms.
Okay, so there is no withdrawal from methadone?
Well, let me finish here. The withdrawal from the heroin is very severe, and so it drives some heroin addicts to go seek more heroin. Methadone, when given, will prevent the withdrawal symptoms.
Okay.
If you take it on a daily basis, and it's usually prescribed for most heroin addicts once a day. Later, they can advance, and some patients get it twice a day. But for most heroin addicts, they'll be taking it as a liquid once in the morning. It'll occupy those receptors so that the patient or the individual does not have the drive to go out and get heroin to avoid withdrawal.
I want to stick with this aspect of it. I want to talk about methadone as used for chronic pain in a second, but right now, just on the drug aspect of it, because it's been in the news lately. There's conjecture that Anna Nicole Smith and her son died from some kind of methadone overdose or drug overdose that may be related to that. So people have been talking about it for a while. What does heroin do to the body that makes people want to take it? And when they stop taking it, what kind of effects are we talking about with a withdrawal that makes it so painful?
Heroin, like many of the substances of abuse, produce a good feeling. That good feeling is generally referred to as a euphoria or a high. But for some individuals, it's just reducing their anxiety. Let me ask you, I get a good feeling when I eat a piece of chocolate cake. Mm-hmm. Are we talking about something that's such a higher magnitude that somebody would be encouraged to take heroin? That's a very interesting point, because all of the things that we get gratification from, whether it is sex, food, or drugs, have to work through the same mechanisms of our brain.
Yeah, so it makes me wonder, how great can it be that people are willing to go through this?
Well, for some individuals, it's very significant, but part of it is when they get started, they're probably treating a mental health problem too. In most instances, there's an anxiety or a mental health problem that gets them started to use it, and it makes them feel normal, if not better than normal and good, and so they keep repeating that good feeling. Once they've done that for a period of time, the body's become dependent on it. So then when it's not there, they have actually a lower level than where they started. And so they need to get back to something to just make them normal.
So it's really a catch-22. It actually makes you feel worse at the end of it than when you started.
Many, many times worse, because of not just the mental state, but now you've got the physical withdrawal symptoms that are really severe.
Give me an example of what you're talking about.
Well, somebody who's got cold chills, an anxiety problem, it works on the anxiety system. If anyone's been nervous or frightened, it's many times worse than what most people would normally experience. You may get diarrhea, abdominal cramps, tremors, so that you cannot literally function or even talk.
Okay, so in a case like this, if somebody wanted to go into a program to help deal with this, you can't deal with the psychological aspects of drug abuse without first dealing with the physical aspects. You can't reach a person who's having cold sweats and diarrhea and stuff like that. So you have to handle that. And am I right in assuming one of the ways to do that is to use methadone as a way of getting rid of those symptoms?
That's correct. It's to eliminate the physical withdrawal component of the addiction, and to eliminate the drive to go get another hit to treat the withdrawal symptoms.
So tell me what methadone does that heroin doesn't, and what heroin doesn't do that methadone does.
Well, methadone. You
know what I mean by that?
Let me give it a shot.
I guess why heroin bad, methadone good?
Methadone
in this context,
they're both narcotics, but methadone doesn't usually produce the high. It can produce a little of a high, but never what a heroin hit can do.
So there's nothing that you could get mentally addicted to with that.
Well, yes, I don't know what you mean by mentally addicted, but
addicted to the high of it, not physically addicted, but addicted to the thrill of taking it.
In most instances, that's not what people would use methadone for. Okay. That's not that. There are many other ways to get more reward.
It doesn't have that aspect that the heroin does.
Far less. It's just it would be far less. The onset of action, for example, the time it takes for you to feel the drug methadone is a long time. It could be 30 minutes, 40 minutes, an hour before you really begin to feel much of it.
Okay. Does it have the same addictive properties that heroin has?
Well, the drugs are not the primary risk factor for addiction. Drugs are, in our society, people think about this drug versus that drug as what is most addictive. They are the pharmacology of the drug is important. And you do have to be able to release what we call dopamine in the brain,
right.
Feed the reward center in order to have a substance of abuse. You have to feel good from the drug. But it is not the most important factor that determines whether an individual becomes addicted to a drug.
Are you saying it's more of an addictive personality?
No, I'm not saying it is a personality. I'm saying that there There are two other aspects that really determine it. Your genetic makeup when we're talking about opioids,
Okay.
as opposed to alcohol or maybe marijuana or something else. With opioids, about 50% of the vulnerability to develop an addiction to opioids is based in your genetics. The other 50% is your environment and the drug. Most of it is environment and mental health. And people who have anxiety disorders, significant mental health problems are at much greater risk of using the opioid to treat that anxiety disorder. Then they become dependent on the drug. And then after they're dependent on the drug, do not want to experience the low if they don't take the drug.
Okay, so of the three aspects then, the first is that methadone doesn't give you the high that heroin does. It doesn't necessarily have the physically addictive properties that heroin does.
It does have the physically it does have those properties.
It does have those.
Yes.
Okay. I assume it doesn't have the what was the word? The withdrawal symptoms.
It does have the withdrawal symptoms, but the issue
Are they
is
as severe as what heroin would be?
they could be as severe if one was on a large amount of methadone and suddenly stopped it, they'd feel very ill, much like the heroin addict.
But if you're in a program, you're not going to be in a large amount.
That's correct.
Okay.
The whole purpose is so that you don't have to go out every few hours
Right.
or a couple of times a day to trying to find something that is illegal, and it's going to smooth things out so that
it's
people
a stabilizing force.
Absolutely. It smooths everything out and prevents the people from experiencing the withdrawal symptoms. So many people, professionals included, have been able to sustain work and wonderful lives their entire life for 40 to 50 years when they've been on methadone.
Okay, but we're having a problem, aren't we, with people overdosing on drugs like methadone? People getting into trouble with this kind of drug, which is used to help you get over other kinds of drugs, at least in this aspect of it. I have here something that says that Utah Narcotics spokesperson Jennifer Bennett Goodall died from a methadone overdose, a drug she was using to keep her sober from a previous addiction. That shouldn't be happening, should it? Now, what is causing stuff like that? Is it doctors not prescribing it properly or patients abusing the drugs that they're taking?
We want to be clear here of two different populations. We're talking about patients who are illegally using methadone,
right,
or that it's being used for the treatment of addiction.
Okay.
That's an entirely different population than the patients who are prescribed for legitimate pain purposes.
Right, and we're going to talk about that in a second.
All right. So if you take the individuals who are being treated for an addiction, it's not clear why people would die from that, but it's more than likely due to an excessive amount, whether it is due to too much prescribed or an individual has overconsumed because they are self-medicating themselves due to some of the adverse effects of their condition, whether it's a mental health problem or if it's because they're beginning to experience some withdrawal symptoms and they don't want to experience that, or they're beginning to crave and they're afraid they're going to go out and get more heroin. They'll take more than maybe what's been prescribed or add alcohol to it or add a sleep aid or something else which makes them more toxic.
So it's part of a larger problem is our culture of not using drugs properly.
Bingo.
And the need to educate ourselves on that.
Yes, absolutely. That's the purpose of me sitting here with you this morning, because our culture doesn't appreciate the magnitude, the power behind all of these medications, the wonderful benefits they can provide, but the treacherous territory that they can also go down if they're used improperly and not as prescribed.
We're talking with Dr. Lynn Webster, who is Medical Director of Lifetree Clinical Research and Pain Clinic and President of the Utah Academy of Pain Medication. I'm Scott Winter, and this is Feedback on the Spectrum Public Affairs Network. Doctor, you know as well as I do, we have become a drug culture. If it's not illegal drugs, it's legal drugs. It's pain medication, it's cough syrup. If we get an infection, we get penicillin. If we get a cold, we take some aspirin. If we can't sleep, we take a sleeping pill. If we feel unhappy, we take the antidepressive medication. If we feel too agitated, we take Ritalin. We are just popping pills and drinking drugs left and right in order to regulate our bodies, and we're doing too much of it, aren't we? I personally think that we are, and we're using it as too much of an answer for every little problem that pops up.
Well, I don't know if I can go there with that. I think that there are a lot of medical conditions that deserve the treatment that is offered. There are people who are overutilizing and perhaps not seeking out the right form of treatments. I think that's all true. I don't know that I can go and say that.
Walk down the drug aisle of your average grocery store any day of the week and just tell me how many different products and how many different brands you run across, because they're all over the place. We're looking on science as a way of fixing us physically.
Fortunately, science has been there to help us with a lot of problems that otherwise we wouldn't have been able to solve.
But now we're doing it for every little thing that pops up. At least that's my opinion. You're not seeing that in your work?
Well, that's something I think that probably exists for sure. I think that there is a problem with overutilization of a lot of medications,
overprescribing of medications.
There may be some overprescribing, but I can say that in the area where I'm an expert, I don't believe there's an overprescribing in a global general sense of pain medications. In fact, I think there's far less than has been needed. There's far more undertreated pain than there is overtreated.
You know what I think that the reason for that is because I don't think a lot of people actually believed in the idea of chronic pain syndrome for a long time. They didn't really, they thought people were just complainers or making a big deal out of little things. They didn't understand that, hey, you may be a guy, I may be a guy, we may even be the same age, but that doesn't mean our bodies work the same. Our bodies are different, and what works for you may not work for me. So the idea that I'm not going to prescribe you extra pain medication for your problem because I think you're faking it or I think you're making a big deal out of nothing.
Particularly if it's not obvious as to if you're not bleeding sometimes, then
true.
You know, how am I going to fix it?
If you don't have a gaping flesh wound, a lot of people aren't going to take you seriously.
That's true for a lot of physicians and certainly for family and friends who don't understand why somebody's complaining about their pain.
All right, I want to talk about methadone again, and tell me how you use it at the LifeTree Clinical Research and Pain Clinic as a way of dealing with chronic pain and how it helps you guys.
Methadone's inexpensive. It's one of the least expensive, strong pain medications that we have, and so it has a huge place in the treatment of chronic pain.
Is it synthetic?
Yes,
okay. It
is. It was developed specifically for the purpose of treating heroin addicts for addiction. But some 20 years ago, or maybe 30 years ago, it also was prescribed for the treatment of chronic pain. It's very effective. It has some unique properties that make it more effective than most of the other, in fact, all of the other narcotics or opioids that we have available. It's as strong as anything that we have, but it has a unique property that can make it dangerous if you don't use it as prescribed. That is, it has to be taken just as the doctor prescribes, never more than what they instruct you to take. If you take more than what a doctor says, it can become toxic or lethal. You may not wake up. And the reason is the body has to get used to the drug. It sometimes can take a week or two for a body to get used to whatever given starting dose that a patient is given before it's safe to elevate the dose. And many patients don't want to wait.
They get impatient.
Like most of us, like when you had your back problem and you had the pinched nerve, I suspect you wanted to get rid of that pain, and you would do most anything to get rid of that pain.
They give you a little button with a morphine drip on it that you can press every time you're in pain, but it only works every 15 minutes and only for a certain amount. But you know, for the first couple of hours, your finger is constantly pressing that button.
Just as I'm pointing out,
yeah.
You wanted to get rid of that pain.
Yeah.
Imagine having that kind of a pain for weeks to months to years and not being able to work, not being able to do anything. And so finally you get a drug like methadone, and you're given it at a small amount, and by golly, for the first time it started to help.
Well, and you figure if that small amount kind of helps a little, if I take a double dosage, I'm going to feel completely better.
Or 3 times, and if you do that, you may not wake up.
Because the drug doesn't work that way?
The methadone has 2 different half-lives. That is how it works in the body. It's got it will produce pain relief for about 4 to 6 hours. But it's then going into the body and building up and accumulating over a period of time. And the body it stays in the body for about anywhere from 50 to 100 hours. So over a 2 to 4 day period, it builds up, and that part that is building up can suppress breathing. And so by about day 3 to day 4, in somebody who's starting on too high of a dose or is self-medicating to treat their pain, they will reach a toxic and a lethal dose.
Is it supposed to build up in the body that way, or is that only happens if you're taking too high of a dosage?
It always builds up like that,
Okay.
but it's not going to build up to a lethal dose if you start low and keep it low and allow the body to get used to it. So the body develops some what we call tolerance, meaning it gets used to the drug. Now, it will get used to it, so you need to give more for pain relief, but the body has to get used to the respiratory depressant effect.
Okay,
That
that was going to be my next question. If your body builds up a tolerance, isn't that another kind of catch-22 where you always need to be increasing the dosage in order to make it as effective as it once was, because now your body's used to it, so it doesn't work as well?
It's not a linear curve, or it's not a linear escalation forever. What happens is that the body over the first month or two does develop a tolerance. It gets used to the drug, and then you need less and probably can reach a plateau so that you don't need any additional amount of the methadone to maintain the same level of pain. But at that point, then you no longer have as much of a concern about the suppressing the breathing.
Do doctors explain this to their patients? Do most doctors explain this when they prescribe this kind of medication, or do they just tell their patients to take it and don't bother to let them know what the effects would be or what the consequences would be if they did not take it properly?
I can't tell you what most doctors do. I can tell you
Well,
what
let me tell you this. Were you trained to do that? Or did you have to train yourself to do that?
I had to train myself because I never practiced or I wasn't in this field when I was in medical school or in my residency.
Well, it doesn't matter. In medical school and residency, no matter what field you're in, I would think they would tell you to tell your patients about this stuff.
Well,
but it sounds like they don't do that.
I don't know. I don't think that the doctors probably do a good enough job on this particular issue.
So part of the problem could be that we're not educating the patients about the effects of the medication we're giving them. We're just telling them to take it.
I think the bigger issue is that many of the physicians don't understand what I've just said.
Oh, so they don't understand it themselves enough, much less explaining it to their own patients.
That's correct. And that's why I've started this national campaign. I lecture throughout the country about the pharmacology of methadone and why it could be risky and how they need to prescribe it to be safe for their patients. I'm also lecturing across the country, and thank you for this opportunity, to make sure that all of the people of Utah and the people across the country understand this is a unique drug. It's a very effective and good drug, but you cannot take it in ways that could be harmful to you.
I can only imagine that you have had at some of these lectures, doctors come up to you and say, I wish I had known about this earlier because I've lost patients for this reason.
Yes. I have had that happen. They have been very concerned about what they have not known in the past.
Patients, if they overdose on a drug like methadone, it cuts off their breathing?
No, it doesn't cut off. It stops it stops your breathing drive. And all narcotics can do this.
You mean the automatic reflex function that your body does to breathe?
As you and I are speaking now, we are breathing.
Without even thinking about it.
Because we respond to oxygen and carbon dioxide. And we control this. We control this level by our ventilation or our breathing. And that is dampened and sometimes stopped, particularly at night, when there's less stimulus.
Is that sleep apnea or is that something else?
Well, I think it is a form of sleep apnea. It's what may be considered total apnea. So if you're asleep, apnea means no breathing, so you're not breathing when you're asleep. It's not obstructive sleep apnea that many people hear about, where there's an effort to breathe, but you can't get the oxygen in and out, or you hear that heavy snoring. That's an obstructive component, but that's different than the fear or the condition that I'm concerned about.
Does it take a lot of overdose of the medication in order to do this, or can just a little bit be enough of a problem?
Unfortunately, if it's the wrong individual and the wrong body size, somebody's overweight, heavy, also on some other medications, it could take a small amount on the first time of taking the medication that could be lethal.
What are the symptoms for something like this?
Well, you may not know it, but certainly if you're fatigued and if you are very tired and you have some slurred speech, you've got too much medicine. And hard to awaken, if you go to sleep, you're falling asleep in your chair with taking this medicine, it is something to look for.
Okay. And doctor, are you getting a good response from going around to other physicians and letting them know about this? Or is it like, hey, I know how to do my job. Don't you tell me how to do my job?
No. Everyone's very much appreciative.
Yeah.
Everyone that I've spoken to nationally, locally, is very much appreciative of this information. And in fact, they're asking for more and more of my time.
And are you getting? Are people starting to understand more about what a problem chronic pain can be?
Yes, indeed. Over the last decade, that is the awareness of that has also increased. And what we're trying to do is make sure that we always have access to medications like methadone and morphine. At the same time, we don't want over-treatment or over-utilization of the medications.
Okay. Tell me about a website. I know you have one that people can go to find out more information about this, about the whole idea of proper medication for patients.
Our website is zerodeaths.org.
So you don't want to have any deaths because of this.
My goal is, at least for the state of Utah, to eliminate all deaths that are unintentional, accidental deaths within the year.
Well, especially when you're dealing with a death caused by something that was supposed to make things better.
If it's accidental and it's either been because a physician overprescribed or a patient has overutilized, we can eliminate that problem. That is simply an education, and I'm hoping we can achieve that.
And this is the reason the Utah Academy of Pain Medicine, which you're the president of, was founded in the first place, right?
It's part of the reason. It's for patient awareness, to make medication safe, and for us to be able to continue to treat our chronic pain patients.
How many doctors locally are members of this?
I think about 30 or 40.
Okay.
Yes.
And you're getting cooperation from hospitals with this as well?
Yes, absolutely. I've been lecturing in most of the hospitals, and we have many others set up for the rest of the year.
Well, doctor, you want to make sure people find out more information about this? Give that website one more time.
www.zerodeaths.org.
Dr. Lynn Webster, Medical Director of LifeTree Clinical Research and Pain Clinic and President of the Utah Academy of Pain Medicine, thank you for being on the program. We appreciate it.
Thank you very much.
I'm Scott Winter. This has been Feedback on the Spectrum Public Affairs Network, and we'll see you next week.
You've been listening to Feedback with Scott Winter on the Spectrum Public Affairs Network. If you have comments or suggestions about Feedback, please write to us at Feedback in care of Scott Winter, Clear Channel Broadcasting, 2801 South, Decker Lake Drive, Salt Lake City, Utah, 84119. Or you can email us at feedbackutah@clearchannel.com. Feedback is a presentation of the Spectrum Public Affairs Network. Salt Lake City, North Salt Lake, Ogden, and Provo.
This is the Spectrum Public Affairs Network.